from injury when the head is struck. It acts like a cushioning effect or something, providing for the gliding of the brain whenever there is an injury. But of course that doesn't become a main important function because the amount of cerebrospinal fluid is very thin and the membranes are in close opposition. It circulates in the subarachnoid space, they are in very close opposition. It doesn't offer that amount of cushioning effect to the brain as is expected. So that doesn't become a very important function here. Let us look at the other options. Pressure slightly lower than the venous pressure in the recumbent position. The pressure difference between venous system and cerebrospinal fluid is markedly variable. It depends upon the position where the person, whether the person is in sitting or lying down position. In lying down position, the pressure is markedly low. So the difference is not this narrow. It has to be a wider difference. Okay. So C and D we have ruled out. Of the two, provides for the greater part of the nutritional requirements. It does not supply any nutrients to the brain. It has no function related to supply of nutrients. So we are left out with only one, ultrafiltrate of plasma. Now somewhere this also doesn't look very appropriate option. So of the four, truly speaking, none of them are correct answers, because when it is formed, when cerebrospinal fluid is formed, at the time of formation, it is an ultrafiltrate. In the choroidal plexus, the formation occurs in the choroidal plexus, which is present in the lateral ventricles of the brain within the cerebral hemispheres. The lateral ventricles are there, ventricular system. In that, the choroidal plexus secretes, filters initially actually. So it's an ultrafiltrate. Later on, there are so many modifications brought about in the CSF. So at the time when it reaches its actual circulation in the subarachnoid space, it's no longer an ultrafiltrate. Okay. So because of the secretion, reabsorption, changes brought about, truly speaking, it's not an ultrafiltrate. But at the time, if we consider at the time of formation, definitely it's an ultrafiltrate. So among the given options, the closest is option A. That is, it's an ultrafiltrate. Now, similar question which has appeared, which is cerebrospinal fluid. The four options are: is actively secreted by the choroidal plexus, it has a major source of brain nutrition, has the same pH of arterial blood, virtually glucose free. Now looking at these four options, the one which we can easily rule out is it doesn't supply any nutrients to the brain. The nutrients to the brain are basically supplied by blood supply itself. Okay, CSF has no role in that. Among the three other options, the pH of the arterial blood, they say that CSF has same pH as the arterial blood. No, it's slightly acidic when compared to the pH of the arterial blood. pH of the arterial blood is very strictly regulated between 7.38 to 7.42. This is slightly lower than that, towards the acidic side. Virtually glucose free. Now some amount of glucose is normally present in CSF, which accounts for 2/3 of the glucose which is present in the plasma. If the normal plasma glucose level is taken at somewhere around 100 to 120 mg per dl, 2/3 of that is somewhere around 50 to 80 mg per dl is the normal CSF glucose value. So it's not glucose free. We are again left out with only one option, that is its secretion. It is actively secreted by choroidal plexus. This is the most appropriate option when compared to the previous question. Here it says actively secreted, whereas an ultrafiltrate is a passive process. It is just passive process, whereas active secretion is involved here. So this option A is most appropriate here. So we'll go for option A. On pressing the jugular vein, they mean to say internal jugular vein. Let us assume it is IJV, internal jugular vein. CSF pressure increases, decreases. There is no change. There is a crescendo decrescendo pattern in the CSF pressure. By crescendo decrescendo pattern, I believe that they are saying initially the pressure rises and then there is a fall in the pressure by applying a pressure over the IJV. Whenever there is pressure applied over the IJV, the intracranial pressure rises. So that is reflected by increased pressure, increased CSF pressure. CSF pressure is nothing but a reflection of the ICT, intracranial tension. Higher the intracranial tension, higher is the CSF pressure. So because of pressure on the IJV, ICT rises, raised ICT reflects as increased CSF pressure. Okay, a few facts about CSF. Volume, normal volume of CSF is only 150 ml Total normal volume is 150 ml. This has been asked in several MCQs. Range is 100 to 200. Now, the pressure in supine position is measured in, generally the CSF pressure is measured in centimeters of water or millimeters of water, either water or CSF, but it's generally not expressed in terms of mercury. It can be converted to millimeters of mercury also. So the CSF pressure is 15 centimeters of water in supine position when the person is lying down. And the most important factor, this has been asked again as an MCQ, the most important factor that determines CSF pressure is absorption, not secretion. Secretion has got nothing to do. Only when the absorption is hindered, there is blockage to the absorption, CSF pressure rises. Absorption is done by arachnoid villi and granulations. Arachnoid villi, arachnoid granulations. These are the main structures which cause absorption of the CSF. Now the rate at which this is formed is 0.3 ml per minute it is secreted. So that accounts for somewhere around 500 to 550 ml in a day. That is almost 4 times the total volume of the CSF. So every day it gets circulated 4 times. The entire CSF is circulated 4 times, 3 to 4 times in a day. Specific gravity of CSF is low because the solutes are low, 1.005. Reaction is slightly alkaline. On the alkaline side of the neutral pH, 7, but slightly acidic when compared to the blood pH. 7.38 is a blood pH. This is slightly lesser than that, but still more than 7. So that makes it slightly alkaline. Site of production, choroidal plexus in the lateral ventricles. There is some contribution from the ependymal cells also. They also secrete to some extent. The water in the CSF is the main constituent which comes by transduction mechanism. That is, it is a process of osmosis. That is, along the gradient it moves. Transduction. Solutes are all actively secreted within the CSF. The pressure depends upon the position, as I said before. In lying down position, it is 13 centimeters, which is equivalent to around somewhere around 10 millimeters of mercury. 13 centimeters, 10 millimeters. The difference you need to note there is this is in centimeters, that is in millimeters. So it's almost 1/10 of the water. When you are describing in terms of mercury, it is 10 millimeter, whereas in terms of water, it is 13 centimeters or 130 millimeters. So it is almost 1/10 less. In lateral recumbent position, it is slightly more, 10 to 18, that is somewhere around average 14. Sitting position, it's still more. So lying down position least, lateral recumbent when the person turns. When we use lateral recumbent is while giving lumbar puncture, while doing a lumbar puncture or giving anesthetic agents, we use lateral recumbent position. In that it is 14 centimeters. And then if the person sits up, upright position, it is 30 centimeters. Now what are the events that are going to alter? Events like coughing and crying, they increase the CSF pressure by decreasing absorption. Whenever there is coughing, there is crying, there is pressure, increased pressure over the arachnoid villi and granulations which get obstructed, no drainage, increased CSF pressure. Compression over IJV, as we said before, also increases the pressure. Ratio of glucose is 0.64. Ratio of CSF glucose to plasma glucose is 0.64. That is roughly it is 2/3 of the plasma glucose. Now when the pressure goes on decreasing, we said in the lying down position it is 13 centimeters or 130 millimeters of water. If it goes on decreasing to somewhere around 70 or 68 millimeters of water, CSF pressure is going to completely stop. So we need a pressure above 70 millimeters of water for its regular absorption. Cells, there are only less 5 cells per high power field in CSF. Cells are very minimal, and whatever cells are there, majority are all lymphocytes with few monocytes here and there. There are no neutrophils present in CSF normally. If we find neutrophils in CSF, we should suspect bacterial meningitis. In viral and tubercular meningitis, there is increased lymphocytosis. Presence of increased cells in CSF is termed as pleocytosis. Pleocytosis is the term where we find increased number of cells in the CSF. More of neutrophils, bacterial, more of lymphocytes, viral or tubercular meningitis. CSF protein can sometimes be very low. Normal CSF protein is in the range of 30 to 45 mg per deciliter. That's the normal range. It can sometimes be low whenever there is a CSF leak. If CSF leak occurs, the protein becomes low. The other conditions include leukemia, pseudotumor cerebri, which can be seen because of vitamin A intoxication. There we find low CSF protein, hyperthyroidism, and children generally have lower CSF protein when compared to adults. Okay, this is the composition. Main constituent is water, 99%, solids account for only 0.87%, very less, so that makes the specific gravity very low, 1.005. Solids are organic and inorganic. Inorganic, sodium, calcium, potassium, magnesium, these are the ions, chlorides, phosphates, bicarbonates and sulfates. The organic substances include proteins, amino acids, sugar, cholesterol, urea, uric acid, creatinine and lactic acid. The only cells are lymphocytes, 0 to 6 per cubic millimeter. This is the pathway of circulation. It's basically formed in the lateral ventricles of the brain cerebral hemispheres. From there, through the foramina of Monro, it enters the third ventricle. From the third ventricle, through the aqueduct of Sylvius, it enters the fourth ventricle. From the fourth ventricle, there are two foramina. One is foramina of Luschka and another one is the foramina of Mejendi, through which it enters the subarachnoid space. It circulates through the subarachnoid space and then it can enter the venous sinuses through the arachnoid villi and granulation. It also circulates through the central canal of the spinal cord and the perispinal, the subarachnoid space that sheaths around the spinal cord. This is the circulation of the CSF. There are questions which are framed on presence of substances in CSF, which are more in CSF, which are more in plasma. Substances which are more in CSF to be remembered are chlorides are more, magnesium is more, bicarbonate is more, and partial pressure of carbon dioxide is more in CSF. Creatinine is slightly more in CSF. So chloride, magnesium, bicarbonate, partial pressure of carbon dioxide, PCO2 and creatinine, more in CSF than plasma. Substances which are less in CSF than plasma are potassium, calcium, proteins, glucose. Glucose is 2/3. Glucose we have already seen, 2/3. Inorganic phosphates, urea, uric acid, cholesterol. So generally all the organic substances in general except for creatinine are all lesser in CSF when compared to the plasma. The ions, majority of the inorganic compounds are more in CSF when compared to plasma except for potassium and calcium. Now one ion which we have left is sodium. Sodium is equal in both CSF and plasma. So that gives same osmolarity to CSF as well as plasma. Okay. Moving on to the next subset in something related to the CSF is formation of the blood-brain barrier, the question says it is formed by microglia, oligodendrocytes, astrocytes, Schwann cells. These are the options. Any idea? Oligo. Among these four cells, which you want to go for? Among the given options. Why I am saying so is because none of the options are exactly appropriate for formation of blood-brain barrier. Among the given options, I think we can go for astrocytes to some extent. Okay. Let us see the other cells. Microglia, the glial cells in the brain are divided as macro and micro. Microglia have mainly phagocytic function. They are the phagocytes. Like we have the dendritic cells, Langerhans cells, Kupffer cells, these phagocytic cells throughout the body. Microglia are the phagocytic cells in the brain. Whenever the brain neurons are dying, microglia will form a sheath around them. This is called as neuronophagia. They eat the dying neurons. That's called neuronophagia, which is seen in so many degenerative disorders. So microglia play a phagocytic function. Now oligodendrocytes and Schwann cells have same function inside and outside the central nervous system. Inside the central nervous system, myelination of the neurons is done by oligodendrocytes. Myelin sheath around the myelinated nerve fibers is done by the white matter. Whatever the white matter is there in the CNS, the nerve fibers passing through them, the myelinated ones are myelinated by oligodendrocytes, which are one of the types of macroglial cells. Macroglia are mainly astrocytes, oligodendrocytes and ependymal cells. These are the macroglial cells. Among them, oligodendrocytes form the myelin sheath in the CNS, whereas outside the central nervous system, the myelin sheath is formed by Schwann cells. So basically, oligodendrocytes, Schwann cells have same function, myelination of the nerve fibers. Inside the CNS, it is oligodendrocytes. Outside the CNS, it is Schwann cells. Now we are left with astrocytes, which are the main glial cells. They are the supporting cells in the CNS. Their main function is to proliferate in response to injury to the CNS. In CNS, please remember, there is no fibrosis. There are no fibroblasts to form fibrous tissue. So whenever there is injury, trauma to the grey matter, the neurons of the CNS, the repair is not by fibrosis, the repair is by gliosis. Gliosis, that is proliferation of the glial cells, and mainly astrocytes are the one. Now coming to blood-brain barrier. Now blood-brain barrier is a barrier that separates plasma or the blood in the circulation or in the blood vessels from the parenchyma of the brain, the grey matter of the brain. It is separated. Why we need to separate? We need to separate to protect the brain parenchyma from all the harmful toxic substances, infectious agents that are circulating in the blood. So how to ensure that this doesn't happen? The infection doesn't pass through or toxic substances do not enter. So by formation of this barrier. How this barrier is formed? This barrier is basically formed by the tight junctions between the endothelial cells of the blood vessels. When compared to endothelial cells elsewhere in the body, everywhere in the body, the endothelial cells have some amount of gap, which are known as fenestrations. These fenestrations are normal feature of blood vessels throughout the body. But in CNS, the blood vessels have very tight junctions and there is no fenestration at all. And the protein that is involved in forming these tight junctions in CNS is called occludin. Occludin is the most important, supported by claudin to some extent. Claudin also, that's an MCQ. Occludin and claudin have been named as the proteins which play a major role in forming the tight junctions between the endothelial cells of the blood vessels in CNS. Okay, that's the most important thing. Now, these tight junctions are to some extent reinforced by two things. One is the presence of pericytes around these blood vessels. These are supporting cells that form a sheath, and the glial cells, especially the astrocytes, send foot processors, they send cytoplasmic processes which come and ramify around the blood vessels. So what we have basically is, we have these endothelial cells which are flattened cells. These are the nuclei of the endothelial cells. Okay, this is the lumen of the blood vessel. The blood is flowing. These endothelial cells are basically having tight junctions at their junction. Okay, now this doesn't allow any toxic substances to pass through like this. It is stopped by the tight junctions. Now to support this, we have another supporting cells called as pericytes, and to some extent these are the glial cells. Their foot processes come and ramify around these tight junctions. So three things. One is the tight junctions, most important thing. Second most important thing, the pericytes. Third most important thing, the foot processes of astrocytes. So among the given options, we had only astrocytes, so we are going for astrocytes. But if all other options are given, the tight junctions between the endothelial cells of the blood vessels is the most important reason for formation of blood-brain barrier. Okay, so moving on, this is the image which shows the tight junctions between the endothelial cells which are supported by the pericytes and the foot processes of astrocytes which are ramifying around them and giving support. Okay. Now, though this barrier is present, it does not stop everything. It stops only few things. So there are some things that can pass through blood-brain barrier. Which are the things that can freely pass through? Oxygen freely passes through the blood-brain barrier. Carbon dioxide freely passes through. So always remember, gases have no barrier function. So gases can freely pass through. Numerous MCQs have been framed on blood-brain barrier in physiology, medicine, pediatrics. Okay, so it can be asked in any of those subjects. Even to some extent in toxicology also questions have been framed on this. Oxygen and carbon dioxide are freely permeable. Water definitely freely passes through. Glucose, nutrients like glucose and amino acids freely pass through. Electrolytes, the BBB cannot stop electrolytes. There are some drugs which can freely pass through. L-DOPA. What is the application of this? Passing of L-DOPA through the blood-brain barrier and entering the parenchymal cells. Where are we going to apply this principle? In Parkinsonism, because dopaminergic neurons are destroyed in the substantia nigra, L-DOPA is a precursor. Dopa decarboxylase enzyme is going to convert L-DOPA into dopamine. If we give directly dopamine, dopamine is not going to pass through the blood-brain barrier. L-DOPA passes through. That's why L-DOPA can be given. 5-hydroxytryptamine, that is serotonin, passes through. Sulfonamides, tetracyclines, and many lipid-soluble antibiotics. Drugs like sulfonamides and tetracyclines freely pass through the blood-brain barrier. And very important application of drugs passing through blood-brain barrier is anesthetic agents which are lipid-soluble. Most importantly, ether and nitrous oxide. Both these anesthetic gases are lipid-soluble, highly lipid-soluble, so they pass through the blood-brain barrier and enter the CNS. Any other lipid-soluble substance, especially alcohol. Alcohol passes through the blood-brain barrier and causes intoxication at higher doses. Now, the substances which do not pass through blood-brain barrier. This is also equally important as far as MCQs are concerned. Injurious chemical agents, especially organic chemicals like acetone, carbon tetrachloride, so many injurious organic chemical compounds do not pass through. Pathogenic agents, especially those bacteria and larger molecules, they cannot pass through these tight junctions. The space between the tight junctions is very, very minimal for this large size bacteria to pass through. Drugs such as penicillin and catecholamines do not pass through. So, because catecholamines cannot pass through during physiological stress, the direct action of fear reaction, the emotional stress is not present on the parenchymal cells of the brain. Dopamine also, as we saw, dopamine also doesn't pass through. That's why we use L-DOPA as the substitute. Plasma protein do not pass through the blood-brain barrier. That is albumin, globulin, prothrombin, fibrinogen do not pass through. Bile pigments generally do not pass in adults. But what happens in newborns, the blood-brain barrier is still not very well developed. So, if there is hyperbilirubinemia beyond somewhere around say 15 or 20, severe hyperbilirubinemia, the child is susceptible to kernicterus, that is damage to the brain because of the bilirubin, because BBB is not yet developed. But if the BBB is developed, it is impermeable to bile pigment. So, in adults, severe hyperbilirubinemia is unlikely to cause kernicterus. Okay, so there are some structures which are physiologically designed in such a way that they are outside the blood-brain barrier. There is a specific function for these structures. It's not that nature forgot to encase them in blood-brain barrier, they were deliberately left outside. So, which are these structures? All these structures are present around the ventricles of the brain. That's why they are together collectively called as circumventricular organs. Circum means around the ventricle, circumventricular organs. Which are they? The most important neurohypophysis, that is posterior pituitary. Median eminence of the hypothalamus, which is directly related to the posterior pituitary again. Area postrema of the brainstem, organ vasculosum of lamina terminalis, and subfornical organs. All these structures are outside the blood-brain barrier, but beware, remember very well that they are not outside the blood CSF barrier. Blood CSF barrier is very strongly developed in these structures. It's only the blood-brain barrier that is not present. There are a lot of fenestrated capillaries which perfuse these vessels, because whenever there is any injurious substance or toxic substance metabolite that is present in the body, through these fenestrated capillaries, it stimulates these structures, and these structures in turn reflect the afferent impulse to the important vital structures in the brainstem, thus controlling the vital regulatory mechanisms of the body. We want the vital regulatory centers to be not exposed directly to the toxic substance, but we want somebody else to do this job. For that, these structures have been left outside. So, they are taking the message and passing on to the vital structures like the circulatory and the respiratory regulation centers.